Welcome to the Georgia High School Association presentation on sudden cardiac death, how to protect your family. Why are we here? What is sudden cardiac death? What are some causes of sudden cardiac death? Some prevention strategies, recognition and actions to take if sudden cardiac death is suspected. Senate Bill 60, called Jeremy Nelson and Nick Blakely's Sudden Cardiac Arrest Prevention Act, was apprised March 2019. It states all Georgia schools, public and private, including charter schools, that have one or more grades 6 through 12 shall hold an informational meeting twice per year regarding the symptoms and warning signs of sudden cardiac arrest. At such informational meetings, an information sheet on sudden cardiac arrest symptoms and warning signs shall be provided to each student's parent or guardian. In addition to students, parents or guardians, coaches, and other school officials, such informational meetings may include physicians, pediatric cardiologists, and athletic trainers. Cardiac arrest is the leading cause of death in young athletes. It is rare, but when a young, previously healthy athlete dies suddenly on the playing field, communities can be devastated. Young athletes are perceived to be a healthy group of individuals. They aren't supposed to die. When this happens, it can stir up media attention, discussion, and sometimes finger-pointing among school personnel, coaches, administrators, parents, and physicians. We're going to be discussing some causes of sudden cardiac death in young athletes. The four main causes are structural abnormalities of the heart, electrical abnormalities of the heart, trauma to the chest or heart area, and infectious diseases. By various mechanisms, these abnormalities cause the heart to beat out of control, called ventricular fibrillation, or VFib. This leads to the inability of the heart to pump blood to the brain, lungs, and the heart itself, causing hypoxic injury, which is the lack of oxygen delivery, and ischemic injury, which is the lack of blood flow, and death. Some structural abnormalities that we're going to discuss include hypertrophic cardiomyopathy, or HCM. This is an inherited condition. It may run in families, so a history of sudden death in a family member before the age of 50 may be the only clue to the condition. The heart muscle walls are thickened, which disrupts the flow of blood from the heart and disrupts the heart's electrical system during exercise. This can lead to ventricular fibrillation, VFib, or cardiac arrest. A history of shortness of breath, chest pain, or syncope, which is dizziness, during exercise may be a clue. Physical exam is usually normal, but a skilled physician in cardiac auscultation may detect a murmur. Some other structural abnormalities include coronary artery abnormalities. The arteries that supply the heart muscle itself are connected abnormally and may get compressed during exercise and not provide adequate blood flow to the heart muscle. This results in VFib and cardiac arrest. Sudden death is usually the initial clue, but there may be a history of chest pain or syncope with exercise. Another structural abnormality is Marfan syndrome. This is an inherited condition, so family history may be a clue. It is a condition which has abnormal collagen in the aorta, and it may rupture with exercise. Some characteristic traits include being tall, slender, having long arms, legs, fingers, abnormally shaped breastbone, high arched palate, extreme nearsightedness, a curved spine, and flat feet. If any of these traits are noticed in an athlete, it should raise suspicion of this condition. A very common electrical abnormality condition is called Wolff-Parkinson-White syndrome, or WPW. It is an extra electrical pathway in the heart which causes rapid heartbeat leading to VFib. They are usually born with the condition, and it can cause chest pain, syncope, and shortness of breath with exercise. Another common condition is long QT syndrome. This is an inherited rhythm disorder causing fast, chaotic heartbeats, often causing fainting. This can result in VFib. This may occur with immersion into cold water, such as swimming and diving. A history of drowning or near drowning in a family member may be the only clue. Traumatic injuries to the heart can include commotio cordis, which is blunt trauma to the chest from a projectile, usually in lacrosse, baseball, or hockey, or contact sports, martial arts, and football, at exactly the wrong time in the cardiac electric cycle may induce VFib. This is more common in children due to a thin and compliant chest wall. Infection can also be a leading cause of sudden cardiac death. Myocarditis is inflammation of the heart muscle, usually from a virus. It causes an inflamed heart muscle, which can't tolerate the stress of strenuous exercise and causes it to go into VFib. Recent viral illness, such as cold or flu, fever, or recent exercise intolerance may be a clue. Athletes with fever or recent febrile illness should not exercise until they are afebrile, symptom-free, and have completed a gradual return to exercise program symptom-free. Let's discuss some prevention strategies. Primary prevention is to recognize the warning signs of sudden cardiac death if they occur. Recognize chest pain, shortness of breath, or syncope with exercise. Syncope in the middle of exercise versus at the end of a race, or fainting suddenly with loud noises such as an alarm clock, phone ringing, or doorbell warrants investigation. Chest pain or shortness of breath, often due to asthma or being, quote, out of shape, but these symptoms need to be investigated prior to returning to strenuous workouts. Remember Senate Bill 60. Sudden, unexpected death in a family member before the age of 50 is also a red flag to a possible inherited condition and warrants investigation. Drowning or near drowning in a family member could indicate long QT syndrome. Family history of known cardiac disorders, Marfan syndrome, or electrical abnormalities of the heart also warrant investigation. Now let's discuss some prevention strategies. It is important to get a yearly pre-participation physical exam by your primary care physician, which is usually your pediatrician. GHSA requires this form as of 8/1/2019 and will not accept any other versions. A thorough history and physical exam by a skilled physician is the primary screening tool in preventing SCD. Mass pre-participation physical screenings in gymnasiums should be discouraged because this format, despite being popular, often doesn't allow for a thorough history or careful cardiac auscultation due to the noisy environment. It may also be performed by a provider that is not the athlete's primary physician. It's usually an orthopedic surgeon, which is not skilled in cardiac auscultation. Previous health records also are not available and unable to update immunizations with this format. Family history may not be reviewed by parent and may be inaccurate and possibly miss important family historic clues that may be causes of sudden cardiac death. Recognition and actions are very important in SCD. Personnel must be able to recognize SCD. Whether you see them collapse or not, you must assume SCD as a possible cause. Act quickly, call for help. Be trained and certified in hands-on CPR. Obtain the AED as early as possible and know how to use it. Every minute is critical. Have an emergency action plan and rehearse it. Designate personnel assignments for CPR, AED, crowd control, calling 911, unlocking the gate, and directing EMS. Equipment location and accessibility should be known by all personnel. It is also important to have a working phone. In summary, it is important to get a pre-participation physical done by a pediatrician 6 weeks before the season starts. This will allow for adequate follow-up should any symptoms be noted or develop. Know accurate family history and be familiar with warning signs and symptoms. Recognize warning signs and symptoms if they occur. Have all coaches and personnel CPR certified and AED trained. Know where the AED is.